I told you
Like,
that story, right? Where like the advice I got from my attending when I was going to be an attending was when you have to make a real decision by yourself, just try not to throw up. That was the advice. But also that you have, and this is not to be paralyzing, but I think you have more power than you realize.
hello there. Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. So I think we were just starting to talk about all of the different ways that a psychotic-like experience can look like psychosis, but it's not quite psychosis. This is especially important in children and adolescents who really don't know how to express themselves very well. So they might be experiencing their internal voice tell them, hey, you suck. You got this math problem wrong again. And they might think that it's a voice that they're hearing, but really it's kind of this internal dialogue as they're developing their confidence and competence in school and other places too.
Right. And I think for whatever reason, probably because it's such a normal stage of development, we don't really have a term for that. If we're talking about children and adolescent and their mood, their happiness or their sadness, we talk about alexithymia. We talk about the inability of a child to really be able to identify and describe the mood that they're feeling. But we don't have a similar term for their perception because they're sort of shaping it as they go. So I think in a way, we can't look at a child's perception through adult eyes and have those sort of fixed ideas of what should be quote unquote normal and what should be abnormal. It's much more fluid in the life of a younger child.
Mm-hmm. And if they do have co-occurring autism spectrum disorder, this can really be, confusing because they might be doing something repetitively or maybe really have restricted interests and they might not be socializing very well with others. And so that sort of isolated, withdrawn behavior can raise questions about, well, is there some sort of schizophrenia spectrum disorder going on? So autism, we can talk about more later too, but autism, there's been a lot more research about its link to schizophrenia, spectrum disorder, and the way the genetics gets involved. But another common cause of hallucinations is grief and loss. So a child or a teenager, when they lose someone that they loved and cared for very much, it can be very normal to hear voices of them saying loving things, caring things, or just seeing them, in the middle of the night when they wake up. These experiences are normal, and I still remember we would get consulted in the hospital and something like this auditory visual hallucinations of dead grandmother would come up and you go talk to the kid and it's absolutely warm and protective, these hallucinations. They're like telling them it's going to be okay, you're going to be okay, I'm with you. The positivity of these hallucinations is definitely a good prognostic factor and also protective. So I think how they perceive that hallucination is also important.
And I think the feedback they get can sometimes be important from their family too. If, their parents are upset or disturbed or distraught by the experiences, the kids are much more likely to see it themselves as a negative, scary thing. It's almost like if a kid cuts themselves, they don't really notice it until they see the blood, or they're kind of okay as long as their parents are okay. But if their parents freak out, then the kid is screaming, crying, wailing. So, as much as possible,
Mhm.
taking some stock of how you're responding to the situation as well, and what you might be feeding in to that fear or distress or that interpretation of what's happening.
Mhm. Right. And I think the good enough parent comes in here where it's normal and it's natural to have those moments and to be honest with yourself and think about what you really need. Before you tend to your child, it's important because if you're masking and covering and trying to get by and suffering, they can tell that too. We say this a lot on this podcast, but just to take care of yourself and make sure you're feeling some level of okay, and then tending to your child.
And I don't want to take too much of a side note here, but I agree with you, and I think we do talk about it a lot because it's so important. And we have excellent evidence that one of the biggest predictors for children's mental health is their parents' mental health and well-being. So it is not so just to be clear, when we're saying this, it is not selfish to practice self-care. And being your best will help your child the best. I will
Mhm.
say that again many, many times, but just a chance to insert it here.
Yeah, yeah. So, more differential diagnosis for psychosis, of course, there is depression. We do have diagnostic code for major depressive disorder with psychotic features. And this is when depression is there, you're meeting criteria, and then you have hallucinations, maybe some paranoia, delusions coming sort of in and out with the baseline of depression. This and anxiety disorder, which can also happen quite often, especially with OCD. They kind of all merge together. Sometimes I think the more I do this, the more I feel like a lot of syndromes merge together.
Mhm.
Because if you have depression, it can worsen your anxiety. If you have anxiety, it can worsen your depression. And if you have OCD on top of that, it can worsen everything. So it's just all very interconnected. And I always feel that paranoia is definitely not a specifically psychotic symptom. It's really paranoia comes with depression, anxiety, even like sensitivity rejection with ADHD. And of course, OCD, you're starting to feel like you've done something wrong and you ruminate on that.
Yeah, I think so too. And sometimes I think people can make errors in judgment by following a single symptom or even a collection of a few symptoms to a conclusion without knowing the full picture and without knowing everything else that might be possible. It's I keep using medical analogies, but I think they're relatable. It's as though someone walks into the emergency room with a fever and they say, "Oh, you have a fever. Well, you must have X." Well, that's not true. That's just one symptom. We have to look at a much broader picture before we can decide what exactly is going on.
Mhm. And speaking of medical reasons, there are a lot of diagnoses to consider, especially in younger children. So, of course, we have genetic syndromes. I think those we start to see at a much younger age. And there's also infections, medication side effects, electrolyte imbalances, specifically, things like B12 and folate deficiencies can cause neuropsychiatric symptoms. And then with little kids, you do want to watch for toxic ingestion
Mhm.
and metabolic disorders too. So this does require sometimes a collaborative approach with the pediatrician, internal medicine doctor, family doctor to rule out all the organic medical causes that can lead to psychosis. And so it is interesting because, when we think about a medical diagnosis, it's almost like, okay, now it's a quick fix and we can give them antibiotics, or maybe we can give them, electrolytes correct. But oftentimes it does get more complicated than that. The actual experience of having, let's say, OCD-like symptoms because of a strep infection, or with autoimmune encephalitis, you have psychosis and you get treated with biologic agents and then you recover, but the actual experience that they went through is still can be traumatic. And so, it's not that you give this one medicine and they're fixed and done. It's important to continue the mental health care and therapeutic approach even after things are relatively more settled from a psychosis standpoint.
Mhm.
And so, speaking of also trauma, that is a huge, huge source of psychosis. And I think we could, again, like have an entire episode on this too. But trauma, PTSD, especially childhood trauma, can render someone more vulnerable to developing schizophrenia. And also, there's meta-analysis studies that indicate that if for adults who have had childhood trauma, they are 3 times more likely to have psychotic disorder in their adulthood than those who did not have childhood trauma. So the risk is tripled with childhood trauma. And so there's a lot of studies about, the ACE study and how that can lead to both psychiatric and medical conditions. So trauma is an entirely different animal. It's a very, very difficult thing to address, but it is something to really, really consider. In fact, for kids with psychotic symptoms, I think it's the first thing I think about.
I was just going to say the same thing. I think it's such an important consideration. It's probably certainly my first thing that I rule out or rule in, because even if it's not the cause of the symptoms, it sort of colors everything that's done with the child after that.
Exactly, right. So maybe we can share a little bit of our approach to evaluation, because maybe a lot of people are curious about, well, what would happen if my child has psychotic symptoms and I take them to a psychiatrist? What's the process here? And so we really do believe in a thorough history taking that starts with onset and duration and what it's like, really laying out a timeline of what has happened.
And it's just to step back for a second. It's so important to reflect on what you said, which is that we start with the evaluation. We're not going to jump to treatment. I've heard and I hypothesized that some people might be worried about taking their child to see a psychiatrist or taking their child in for an evaluation because then they're going to end up on medication. And what if I don't like the medication or it's not the right choice? And that's not where things start at all. It always starts with the evaluation and trying to figure out just what is happening first before we even get to treatment.
Mhm. And, we do also assess objectively the mental status. So, specifically, when we are assessing mental status, we are looking at the child, we're observing, and we are interacting with them. We don't have to have like a full-on conversation. It is sometimes just the back and forth can really tell us a lot, especially if there are negative symptoms, of like lack of eye contact or the body language or appearing internally preoccupied. That's kind of the term that we use for people who seem like they are hearing something and they're preoccupied with some other external stimuli that's happening to them. And if they are willing to talk, we do assess for thought content, perception, and any sort of like delusions, paranoia. Of course, I used to think like, oh, it's so easy. You just ask them, are you hearing voices? Are you
Right.
seeing things? Yes, no, yes, no. Done.
Yeah. Are
Not
you
that.
paranoid?
Do you know why you're here? Yeah. But it's really not that simple. And I remember, I think I was on like the residency interview trail and I remember one of the attendings saying, like 10 years in, you just finally start to feel like you get a grasp of this. But then it slips away again. That's psychiatry for you in a nutshell. It's like you kind of get it, how to interview and you get how to assess. And then, you have like a zebra come in and just shocks you. And it's a very humbling field.
And you see
So
how much more complicated it is, and you think that you're just starting to reduce it down to a place where you're sort of on your feet, and then, like you just said, oh, but this syndrome's so similar to this syndrome. How do you tell them apart? And then you start over in a way.
yeah, exactly. And that's why I think, I appreciate doing this podcast because it keeps me thinking. It makes me not fall into this one thing that I believe is right for everybody and it applies to everybody. I think it keeps that brain active. So, and
I always think that the most dangerous combination is if your doctor is very certain and wrong. That's the hardest situation. And so I'd much rather have someone who's open to the fact that something else could be happening or that maybe there's another scan or another expert to see rather than someone who says, nope, it's this. Because anyone who's that definite about something so complicated as psychiatry or the human body, I'm worried they're missing something.
Mm-hmm. Right. And it takes like one Google search, and you have you type a symptom in and it's like 5 million things. So
Hmm.
you can see that the field is still learning and exploring. So your doctor should be too.
Hmm.
So, yeah, and then most of the time, these positive symptoms of schizophrenia are a little bit more difficult to discern because they may say things and you do have to like take that very seriously if they're hearing things, seeing things. But the negative symptoms of schizophrenia, so these are symptoms that are taking away from that person's function instead of adding on, hallucinations and delusions. So, for example, negative symptoms can include impaired facial expression. This is something we call affective flattening. So, decreased speech output is also called alogia. And also just decrease desire and initiation and purposeful self-directed activities and overall decrease in enjoying life and things that are pleasurable. These things are consistent. It's not that they're going away and then coming back and then going away. It's really, really hard to get them out of this negative state. And so with this comes the importance of collateral information. This is something, especially I think as child psychiatrists, we rely on a lot. So, information from, of course, parents, but also teachers, maybe tutors, daycare, any sort of information that you can get of the child in different settings is really helpful. And of course, there's rating scales as well that have been evidence-based, and it's really helpful to sometimes put a number on something.
And just to be clear, these are not things that we would expect families to do at home. These are things that can help a clinician guide their thinking and also follow the rating scales over time. So a rating scale before treatment and after treatment, it's sort of it can be a stake in the ground that helps you know kind of where you are as treatment starts and as treatment progresses and help you reach a more conclusive diagnosis.
Mhm. Right. So as you can see, there's a lot of things we look for. Of course, we do want to check like hearing and visual testing and neurological examination. Oftentimes we work with neurologists, pediatricians, and also get lab work done. So yeah, there's a lot in the evaluation that takes time. And so it is certainly not that after the first meeting, we know a definitive diagnosis. We do have to watch and learn, over time. So, moving on into treatment, it really is a multimodal approach. It's very individualized, and that reflects the vastly complicated nature of psychosis because it's really hard to slap on, a one size fits all treatment approach. First and foremost is medications. Antipsychotic medications are first line. You want to really think about the side effects with antipsychotics. The first line medications for children are what we call atypical or second generation antipsychotics, which can increase your blood sugar levels, increase risk for diabetes. So we want to take a very thorough history and family history of diabetes, high cholesterol, heart conditions. And so we can make sure to monitor that over time. And these medications can cause weight gain. So, regular exercise, healthy eating, those things are also really, really important.
And I don't want parents to be afraid of medication because I think it's very important that we talk about the risks and the benefits, and that's how we as clinicians evaluate which medications to use and whether medications are even a consideration. So the weight gain, the change in blood sugar, the risk for diabetes, all of those are more long-term side effects. And a lot of times, if medications can be started and continued earlier in someone's course of illness, it's actually less likely that they'll need medications in the long term and more likely that they can get off of medication. So I think that almost paradoxically, early treatment and possibly treatment even with higher doses actually reduces the long-term risks of side effects. And that's something that I like discuss with parents that this is not the devil's bargain, right? You don't have to hurt your kid to help them. This is not something that you're doing to, potentially give your kid diabetes with the chance that it will make them better. This is all a very active discussion where we go back and forth and talk about what's helpful and what's maybe less helpful in terms of medication. And it's always the parent's decision. I don't want them to feel like they're giving up control or decision making or power by going to see a psychiatrist.
Mhm. Right, exactly. And I think it's important to discuss openly about what's happening to your child, with these medications. Sometimes there's a lot of fear of dependence, or, maybe it might change their personality in some way. And I think it's important to know that there's just a wide range of things we can do. Some antipsychotics work differently depending on the dosage. Sometimes we can do different formulations, if it's longer acting or shorter acting. And also we can split pills, half a dose of, an indicated dose to mitigate those side effects. So there's a lot of tools that we have, I think, to have that conversation about exactly what's happening. What are you saying? What is your child feeling? It's just really important to discuss together because it is very much a team effort.
And the
Okay.
the teamwork that's involved, it can involve other players as well. So part of the treatment can be medication focused, but part of it is not medication focused. And there are evidence-based, very solid psychotherapies for children with psychotic disorders. There is one called CBTP, which is cognitive behavior therapy for psychosis.
Mhm.
There's FFT, there's family focused therapy, which was predominantly developed for children with bipolar affective disorder, but a lot of the principles and methods can also apply to children with psychotic disorders. So I think it would be a mistake on our part to say, well, you bring your child in, we make the diagnosis, we give them the medication like an antibiotic, right? We give them something and then it's taken away and it's all better. There's a lot more that goes into it, both on the child's perspective in terms of helping them learn and sort of progress in their understanding of what is real, what is not real, what are these perceptions versus where are they coming from, and how do I sort of
Mhm.
ground myself when I'm experiencing something that might not be there. And also for parents, that you're not handed a rule book of how to help your child right away. It's an interactive process. And so the role of, well, what do I do when my child says that they're hearing their dead grandmother? Or what do I do when the school calls and says my child is freaking out because there's a man chasing him around the courtyard and there's no one there? How do I respond to that? That's part of the therapy too.
That is so, so important. The support that they feel from their family members or the people closest to them, that can be in itself a protective factor. It really, really is important, first to sort of not challenge their beliefs. Because that really invalidates them and makes them feel isolated even more. So, oftentimes I'll tell parents to hold a sense of curiosity and kind of ask and help paint the picture with them, so that they feel that there's like an outlet to explain what they're feeling. And now, if this becomes the safety concern issue, like if they're really feeling like somebody's targeting them and they have to go out and get them, that's a different conversation. I think that's when you really need psychiatric and professional help. But if they are having subtle hallucinations, it's really important not to shut them down, because that helps them settle that emotional distress and then be able to access some of the higher order logic reasoning where, oh, wait a minute, it doesn't really make sense. I shouldn't be so paranoid that, all these kids are about to bully me at school. So coming from the perspective of attachment theory is that you do want to hold that complexity with them and for them, and so that they can feel heard.
Some things that we always like to remind families and patients who are experiencing this is that it can feel extremely scary because no one expects these things to happen. It's almost analogous to an earthquake. Everyone has sort of this feeling that the earth is going to stay still, and then when it starts shaking, it's the scariest thing in the world because it's so foreign and it's like everything's moving. And I think
Mhm.
some people can experience this similarly, that all of a sudden the rules of reality seem to be rewritten. And, you're being told that your perceptions are wrong, that what you're seeing is not what you're seeing, and what you're hearing is not what you're hearing. It can be a disconcerting experience, to say the least, for families as well. Um, we are talking about this on the podcast, and we see this. We have a level of expertise in this because families going through this are not the only family to have ever gone through this. And this is uncommon, but it's not so rare. I would say that when I was working in the ER, at least once or twice a week, if not a few times a day, we would get kids who presented with new psychotic symptoms, that this does happen. And that's why we know how to figure it out. So there are resources out there for patients, for children, for families who are going through this. The American Academy of Child and Adolescent Psychiatry has an excellent resource center on this topic. And the idea of finding an expert, finding a therapist, finding someone to help guide you through the process of pulling apart and determining what's causing this and how best to help. We are out here, and it's certainly not something you have to go through alone. There are certainly people who know a lot more about psychosis in children. And I think we're going to be very lucky to have
Mhm.
one of those experts sit down with us so we can talk through his experience on treating these families, treating these patients, and doing research to try to determine where these sorts of syndromes come from in the first place.
Mhm. Yeah, it's actually a quite an exciting field of research. We just had FDA approval on a brand new mechanism for schizophrenia treatment, a brand new medication. And I think it's really robust, this area. And it's something that people really, really want answers for because it's really devastating to watch a family member go through this, especially when there is a familial and genetic component. It makes you worried about what is your role in all of this. So yeah, we are excited to have our guest speaker on and talk more about the firsthand experience of working directly with people with psychosis.